Risk factors of placenta previa. Previous history of placenta previa is most important risk factor because recurrence rate is 5%. Multiparity, maternal age more than 35 years, fourfold increase. Prior cesarean delivery or uterine surgery, Asian woman, infertility treatment, uterine scar, C-section, myomectomy, hysterectomy, prior curettage, multiple pregnancy following ART, succinturate lobes, big placenta, smoking causes placental hypertrophy to compensate carbon monoxide induced hypoxemia, increased maternal serum alpha fetoprotein. Clinical features, symptoms. Bleeding is the only symptom. Bleeding is painless, sudden in onset, causeless, recurrent. Unless labor starts simultaneously, it is painless. In 5% patients, bleeding occurs first time in second and third trimester or during labor in primigravida. In 1/3 of cases, there is history of warning hemorrhage, which is slight, which is unrelated to activity, can occur during sleep. Patient is frightened on awakening to find herself in a pool of blood. 1/3 women present before 30 weeks, 1/3 between 30 and 36, rest third after 36 weeks. There is no bleeding may not be in central placenta previa until labor starts. Asymptomatic cases are detected by sonography or at the time of C-section. Signs. Palar, if present, will be proportionate to the amount of bleeding. Pre-existing anemia cannot be seen or confused. Abdominal examination. Size of uterus is proportionate to the period of gestation and amenorrhea. Uterus feels relaxed, soft and elastic and non-tender. Persistent of malpresentation like breech, transverse, unstable lie is more frequent, and if it is a cephalic presentation, head is usually floating. Increased frequency of teen pregnancy. Fetal head sound usually heard, stall-worthy sign. Slowing of the fetal heart rate on pressing the head down into the pelvis and prompt recovery on release of the pressure is called stall-worthy sign. It is suggestive of posterior placenta previa, but this sign is not always significant because it may be due to fetal head compression even in otherwise normal case. Head is floating in contrast to period of gestation. Persistent displacement of fetal head is very suggestive. Head cannot be pushed down into the pelvis. Vulval inspection. Blood is bright red as bleeding occurs from the separated uteroplacental sinuses close to cervical opening and escapes out immediately. Vaginal examination should not be done in a diagnosed or suspected case of placenta previa.